20 years of low back pain care. What has changed? And what has not? Written by David Evans. Box 1. An acute, non-specific low back pain patient with no red flags. A 28-year-old woman has been suffering from her first episode of low back pain since lifting a 10-kilo box at work 3 weeks ago. She says that she has not been able to do her job managing a hospital cafeteria for this time and has not worked since her symptoms began. While anxious to return to work, she feels immobilised by the pain. Her work duties are varied, but generally involve very few physical tasks. She works full-time during the day and has no dependents at home. In terms of activities, she says that she can sit for about 10 minutes and walk approximately 100 metres before she feels she has to stop due to her back pain. She reports that she is able to sleep through the night. However, her back is stiff in the morning and stiffness lasts for about 10 minutes. There is no history of trauma or serious illness. The pain is limited to the low back area without radiation. On physical examination, there is marked limitation of anterior flexion and tenderness in the left paraspinal region. The neurological examination is normal, and her pain does not worsen in response to straight leg raising beyond 90 degrees. All other case history and physical examination findings are unremarkable, and she has not previously been seen by any healthcare practitioner since her symptoms began. Box 1 contains the text of a clinical scenario that was presented to physiotherapists, osteopaths and chiropractors across the UK, first in 2003 and again in 2023, as part of a study I recently published in BMC Musculoskeletal Disorders. Across the two surveys, more than 3,000 eligible clinicians took part, 1,758 in 2003, 834 physiotherapists, 592 osteopaths and 332 chiropractors, and 1,388 in 2023, 511 physiotherapists, 621 osteopaths and 255 chiropractors. In short, this was a big study that took up many months of my time over the last 20 plus years. Some background and insight. The 2003 survey was conducted as the baseline part of a randomised controlled trial that tested the effectiveness of mailed hard copies of a low back pain guideline awareness pamphlet package designed by the late, great Gordon Waddell as part of a national media campaign in Scotland. Printed clinical guidelines for low back pain, RCGP 1999, along with nice glossy summary sheets for each back pain stakeholder and a copy of the evidence-based booklet for patients, the Back Book. Remember that? This trial was the main study for my PhD at Keele University, supervised by Nadine Foster. The study was so big and exhausting, given that I was doing the legwork on my own, that it added more than 2 years to my intended PhD completion time. Let me give you some insight as to what these numbers meant for me as a PhD student back in 2003. All envelopes had to be stuffed by hand. All questionnaires were photocopied and stapled, and all letters and address labels had to be individually printed, albeit using mail merge, which occasionally crashed. The hand-stuffed envelopes had to be manually taken to and posted out from the university's mailroom. The first wave of invitations were sent out using lists in a database file, either manually downloaded from professional registers or provided as a spreadsheet. We had to manually exclude any clinician in Scotland because of the ongoing Working Back Scotland campaign. We invited 3,604 clinicians in that first wave of invitations. This meant that for every single second spent preparing each posted envelope, on average, more than an hour of time was spent overall. Early envelopes were taking more than a minute to prepare, later ones around 30 seconds. Then I had to track responses every day and clear out the pigeonhole in the post room, which was usually overflowing. Then, for any clinician on our mailing list who didn't respond within a fortnight, a second wave of invitations were sent in exactly the same way. Finally, for the 1,758 baseline responders in 2003, half of these, allocated at random, were sent the pamphlet package by post, and then a further 2 waves of follow-up questionnaires were posted 6 months later. None of this included the time spent transferring the paper questionnaires data over to an electronic database, manually rechecking the accuracy of this transfer in 20% of all questionnaires from each stage, then eventually analysing the data and writing it up. I'm amazed that my then girlfriend eventually became my now wife, given the several near all-nighters that had to be pulled at the physio school at Keele, with her helping me stuff envelopes and deliver these to the post room at all hours. The 2-hour daily round trips up and down the M6 between Birmingham and Keele didn't help either. especially the one when I pranked my parents' estate car that was full of envelope stuffing materials. Once my PhD was completed, I swore that I would never return to the topic again. I'd had enough, which partially explains why I didn't write up and publish the interprofessional comparisons from 2003 alone, although I did present these at a few conferences. My research interests largely moved on to other aspects of pain science, not to mention that posting questionnaires was expensive enough in 2003, over £20,000 at the time, and has become more expensive since. Not least due to the exorbitant postage costs. However, by 2023, there were lots of options to send academic surveys by email, including my beloved RedCap, an excellent tool for researchers that I was already very familiar with. And during the COVID-19 lockdowns, I found myself unable to return to our university labs to collect in-person research data. Hence, the thought crossed my mind that an identical follow-up survey to the same 3 professional groups surveyed in 2003 might not only be valuable, but would also allow me to finally publish